I don't know what, I was thinking about this kid that we did last evening, and Ramani is there. One of the things which I was thinking was the transesophageal ultrasound. So, one of the things that you should think in terms of, doing as well along with your MRCT would be to do a transesophageal ultrasound if nothing comes out of the MRI. So if Raman is here, I've not seen it, but a transesophageal ultrasound is something which could be interesting to consider. So we know all this. There are certain things which are straight from the books, and there are certain things which are more clinical oriented. Now, we all know about the various congenital anomalies and the incidences. Just one thing that that actually allows us to see the cleft larynx in the trachea, which has an incidence of about 0.5 to 1.5%. And if you see the latest publications, this in fact incidence has gone up to almost about 8 or 9%. Means that there is a lot that is missed, and you must remember that there is a lot of misdiagnosis of laryngeal clefts, and today we have good instruments to actually expose the interthyroid area and diagnose the cleft. A lot of these longer clefts, they are associated with other anomalies. There are synchronous associations, and it has syndromic associations. So typical associations with syndromes will be Opitz Fries. So all these midline lesions, Opitz Fries actually cuts through the midline during embryology. So remember of the Opitz Fries, the Ballister Ball, the Bachelor's charges, and always remember that more and more of these associated anomalies, more and more of mortality. Symptoms: feeding problems, aspiration, airway obstruction. Why do you get airway obstruction? Because you have a lot of this redundant mucosa which is pulled inside the airway. There's a lot of excess mucosa in the trachea, and this is what actually creates respiratory problems. We discussed all this in one of our articles that we published many years ago, but this is just to very, very simply tell you what are these long and short clefts about. So if you have an interretinoid area which is cleft, it is type 1. For the younger colleagues here, a cleft would mean that the posterior tracheal bone is not there. So the esophagus and the trachea communicates with each other. The type 2 is where it is slightly and pass through the cricoid. Type 3 is where it is going trans-cricoid, trans-trachea, but it is outside the mediastinum or the thorax. And type 4 is one that goes into the trachea, into the thorax, and then you can move into one of the bronchi as well. Remember, treatment is actually before you start treating them, you need to actually have the child well evaluated. And this highly depends on the cleft extent and associated anomalies. Yes, refluxes, one can correct, but remember that you have a cleft there. So you need to have a strategy to actually correct this particular cleft. But if it is associated with severe refluxes, it needs to be corrected. And overall, in summary, usually all that is extrathoracic can be corrected endoscopically. All which is intrathoracic or long clefts or revision clefts need open surgery. So let's talk about endoscopic repairs. You have to have a variety of equipments, specialized equipments, and I typically will be using an ultrapulse laser, which I think is much more tissue friendly in the larynx. You have more than 30 types of lasers which are available in the market. I think CO2 and ultrapulse is the best suited for the larynx. The endoscopic treatment is basically in the hands of the anesthesia to actually share the airway. So we will talk about a child who has got a cleft which is either a short the CO2 laser, and then from the lowermost part of the cleft, we will actually start coming up on either side till the cuneiform cartilages, and then we will throw a couple of sutures to actually close them. We will use non-invasive ventilatory techniques in these patients. So we have the exposure of the cleft. We use the laser starting from the most distal part, coming on either side till the cuneiform cartilages, till the cuneiform cartilages on the other side. We start suturing them in 2 layers, and then actually, you end up having a result which is pretty good. And what is important to know is, have we been able to maintain the interetinoid distance? Because a lot of times we enthusiastically place these sutures, and that can actually move into a very narrow posterior glottis and a stenotic situation. The endoscopic view has advantages. So we are sitting action on the larynx. So obviously the view into the larynx, trachea, and esophagus is much better. We are able to have conditions optimal to have a normal sized airway, especially the posterior glottis, and all of this redundant mucosa can always be closed as is required. We always do in our patients a toluene blue test, a dilute toluene blue test after a couple of days, and this is the only way in which we can pick up a tracheoesophageal fistula. All kinds of radiological investigations, modified variant, and all those things require interpretation which is correctly done, requires experience, it requires to be done correctly, and it can be quite a tricky situation. So the thing that we actually follow is an esophageal suction catheter, which is actually well placed in the esophagus. We use the dye and avoid excessive spillage. We do a little bit of laryngeal massage, and then simultaneously we put in an endoscope in the trachea and see if there is any kind of spillage. The advantages of the endoscopic repair is that there is no tracheostomy, there is no intubation, we have a good sized airway, and of course the larynx itself, the frame of the larynx is pretty well maintained. The problem is that we cannot, or in certain cases it's not possible. So you need to sort of put the right cases in your books so as to have the right results. Majority of endoscopic procedures have been for type 2s and type 3s, and our operation-specific success rates are about 87%, which require a revision surgery, and they eventually give good results. What is important from our point of view is to know what are the complications that can happen in these patients. Either logically, you will have a complete or an incomplete cleft breakdown. I would give 2 maximum endoscopic attempts. One of my patients, in fact, he had a coagulation factor 13 deficiency. Now, is it really required? This is actually a fibrin stabilizing factor. We gave this factor, it got corrected, and then we re-attempted an endoscopic closure, and the child was fine. Having documented this, no, this was only in one isolated patient, so I cannot actually say for sure. But this is just to sort of give you an idea what happens in these patients. Now, what happens with this factor 13 is that it can be deficient congenitally, or it can be acquired, especially after major surgery or sepsis, which typically is the case in these small and sick children. The residual tracheoesophageal fistula can be compromised, and this is actually what happens if a multiple surgical correction has been done incorrectly. You have an incomplete breakdown of the cleft, you have a residual cleft with a lot of crowding of mucosa, and there we can see, in fact, a tracheoesophageal fistula. If you have a pre-existing tracheostomy and cleft surgery is indicated, again, this is a different talk, but just on a tracheostomy. To give you an idea, if you have to do a tracheostomy, please, the site of your tracheostomy needs to be at least 2 rings distal to the distalmost part of your cleft. Longer clefts, this is going to be a trick situation, but it needs to be evaluated on table. So if you have a residual cleft, residual fistula, or a residual cleft, usually my experience has been that if you have a residual fistula, usually the upper wall that has been reconstructed starts dropping down. So you eventually end up having a type 1 along with the fistula lower down, because there is a lack of mucosal support, and that's the reason why the interetinoid area starts dipping down. Here you can see, in fact, the fistula and the dye going into the trachea, and this is, of course, the residual cleft, which needs to be corrected. So how do we treat these residual clefts? Not in all patients, residual fistulas, not in all patients which can be corrected endoscopically, but we can always give them a try. It is difficult to treat these endoscopically these fistulas, but what we would do is we would clarify that using a brush that is used in cytological examinations in the bronchi or in the respiratory tract, and then throw 1 or 2 sutures lower down and then correct the cleft higher up. Now this is difficult. A lot of people have said that no, it is not possible. No, it's not that it is not possible. Of course it's possible. As you can see here, that you can in fact take 1 or 2 sutures, but you need to have a gouging in the esophagus, otherwise you will catch the posterior esophageal wall as well. So you need to do it correctly to have the right result. And you need to have the right instruments, because you must remember that to place the sutures really low down in the trachea is tricky, especially if the joint does not have any kind of secure area. What is the other way of treating a tracheoesophageal fistula? So this is an open repair. You do a tracheofissure, you identify the fistula, and then of course you close it in 2 layers. This particular joint also had a lot of demolition, so we in fact rigidified the external trachea using polydimensional metal plates. So this is a child who's coming from Austria, 3.5 years, syndromic, mentally retarded. She has had multiple surgeries in other countries and endoscopic and open surgeries, etc., etc. And now she actually has a recurrent type 2 laryngothoracic cleft. She has a grade 1 subglottic stenosis, which is secondary to surgery. And in fact, you can see here that there is an undiagnosed, untreated distal tracheoesophageal fistula. You must remember the parents as well. Now, this child is syndromic and is mentally retarded. It was extremely stressful for this particular family and healthcare providers. She has had multiple hospital admissions in her country since 2014. And this is actually how we prepare her. So the way we actually start doing it is by endoscopic approach. The way exactly what we did yesterday, that I would like to start tattooing my cleft before. And then actually this tattooing allows me to know exactly where is my cleft. And then I can go from outside by doing a complete lateral fissure and then closing the cleft in 2 layers with periosteum or pericondyal connective tissue into positioning between the 2 layers. I always like to put a small mold. Now this is not actually touching the closure behind, but just to sort of give a structure to the laryngotracheal framework, and in fact we treated concomitantly the distal tracheoesophageal fistula. So this is the child in 2017, tracheostomized. Remember, she is mentally retarded. She is on 24/7 non-invasive ventilation, 24/7 oxygen. She has got a very, very complicated care, cannula care. She is exclusively fed and has multiple hospitalizations. After the surgery, the skin had a miraculous change. Remember, she always will have a tracheostomy. What has changed in 2018? She has a tracheostomy, but now the cannula care is much more better. She has just started actually having oral feeds, and now in fact the patch is converted to a peg. So this is the change that we actually do. We are investigating what is the definition of success in neurologically affected patients. That could be having, whether it is subglottic stenosis, whether it is all these congenital anomalies, etc., etc. So I think the definition of success will be different in different kinds of patients. Longer clefts present with different problems. So there has to be a longer and a difficult approach, whereas we do a tracheoesophageal repair by going from the neck and then into the mediastinum. It requires a laryngeal repair as well. One of the procedures which was described by Mike a couple of years ago is basically represented in this schematic diagram, meaning that actually we disconnect the trachea from the cricoid, we pull the trachea in front. So that means that we're exposing the cleft behind. We have the esophagus there, the trachea right there. And then, in fact, we start suturing the esophagus, we start suturing the trachea, we then actually correct the larynx, and then finally, in fact, the trachea is connected to the larynx. This is the child who's come from Tel Aviv, Israel, and let me very quickly go through this video just to show you what is a long laryngotracheal cleft looking like. So you have a huge cleft actually touching the carina, and let me very quickly show you how exactly we approach it. We put in a small Bugatti catheter in the stomach to avoid ventilation problems, and then as we saw it in the schematic diagram, we actually disconnected the trachea from the cricoid. We peeled off the trachea from the esophagus. The child is breathing spontaneously. There is no tracheostomy. There is a tube which is actually in the common esophageal cavity, and then actually the glucosa is mobilized so as to connect posteriorly the trachea. The endotracheal tube is put into the airway intermittently so as to secure the airway. So this is how, in fact, the trachea was corrected. We then went ahead and corrected the larynx with the complete laryngeal fissure, and then the trachea will be connected with the cricoid. Remember, these patients have got severe tracheomalacia. The problem with these open procedures is that there is intubation. Probably will be required to do a tracheostomy, and all these sort of surgical interventions will have an impact on the breathing. If you have to do a midline incision, remember the airway is going to be unstable. There's going to be tracheomalacia associated already on a molastic airway. And remember that posteriorly it is quite technically challenging to put these sutures. Longer clefts means longer morbidity and longer mortality. Tracheoesophageal fistulas are of multiple types. The commonest is this, where you have esophageal atresia with a blind end, and then you have a segment which is missing, and then you have a fistula lower down, which is then actually going into the esophagus and in the stomach. Our role in these patients is basically to put in the Fogarty catheter in this sort of fistula. So here you have the left main bronchus, right main bronchus, and the fistula and Fogarty going in. When you start doing it for the first time, believe me, it's not an easy gait. Sometimes it can be a little difficult. Sometimes you have difficult situations on hand. So this is a 4-month-old boy. He's got that type 3 cleft with an esophageal atresia, and here you can see a quadrification of the carina. Left main bronchus, right main bronchus, fistula, and this is the right upper row bronchus or the bronchus Swiss, typically called the big bronchus. But apart from that, in fact, you have this fistula, and when you look inside the fistula, there is a residual fistula. You can see the Pruny stitch, and in fact, this is a tracheomediastinal fistula. The patients who have esophageal atresia, typically they are dilated for a couple of times, and this patient, in fact, had also an artificially induced tracheoesophageal fistula. Again, the same kind of treatment. We clarify that area, we use these sclerosing agents, and then finally you get a pretty good result with that. The advantage of that also is sometimes it stiffens that area, and the malacia is posterior-anteriorly based because you have a cleft there sometimes, or you have an esophageal atresia, so the tracheal muscle is absent. So by inducing fibrosis, you are able to actually rigidify that particular area. You could use a lot of instruments. Visit your pediatric surgery colleagues, people who are doing urology. You have multiple things by which you can use passing through the bronchoscope, and you can use it in the same way. But tracheal diverticulum is something similar to a Zenker's diverticulum, meaning that, let's say, typically the same example of a type 3. If you ligate it very close, now what the pediatric surgeons do is they actually clip this. So if you ligate this very, very close to the membranous trachea, then it goes into a stenosis. If you ligate it far right there, then it will go into a diverticulum formation, something like this. What would happen if you have a diverticulum? You will have these secretions which are pent up in that diverticulum. So chronic aspiration, recurrent pneumonias can happen because of these secretions which are stagnated in the diverticulum. And if the child has got the tracheostomy, you will have the cannula which actually is going straight into the pouch. the treatment is pretty simple. If you have to go from outside, believe me, it's a nightmare. So the easiest way is to treat it the way we treat Alzheimer's diverticulum. So we use these specially designed forceps which actually can be put into the diverticulum, and then you can apply monopolar cautery, and then you can actually cut the fistula, rather the pouch, so that the pouch actually becomes in the same cavity as the trachea. So if we go into this particular patient, there is a pouch that can be seen, and once we go inside this pouch, you can see that there is no fistula or residual fistula. So this is a pure pouch. That's why in fact we are going into the pouch, and you can see that he has a tracheostomy, and this is where in fact the tip of the cannula goes into this pouch, and he has had a couple of dying spells at home. So you go down and you cut actually endoscopically the party wall between the pouch and the trachea, allowing the pouch to be a part of the airway. And the child in fact did pretty well after this particular surgery. So to conclude, as far as this particular chat is concerned, you must remember that it is rare, but if you haven't seen it, it is rare. It is there. This particular anomaly is there. The management is basically related to the air control. You have to control the aspiration and the repeated lung infections. The endoscopic repair, you need to have dedicated anesthesia and surgical teams. Remember, the instrumentation needs to be there, but you are operating in a very, very narrow area. Longer and revision clefts require an open surgery. Thank you very much for your attention. Any questions?
Can you see the nitrogen
Nitrogen. I haven't seen it, but I could imagine that the mucosa has been stripped off. Either by any kind of tracheobronchial surgery or rigid instrumentation. So I could imagine that the mucosa has been stripped off, causing the diverticulum. I could imagine that, but I haven't seen it happening in our sort of setting. But I can imagine it can happen.
I've seen it post-ventilation.
Post what?
Post-ventilation.
Post-ventilation. Yeah, but if you don't have trauma, it's hard to imagine how can you have a diverticulum related to that. So I could only imagine that the endotracheal tube was shoved in so badly that the posterior tracheal bone was stripped off, and then the endotracheal tube, the tip was staying in that traumatized area. You have the mucosa in front, which was flapping around, and then the patient was ventilated with that. Endotracheal tube was removed, then that strip actually remained as a floppy area, and then that formed into a pouch. I can imagine.
Actually, that patient I must follow.
But I think adults, if it was an adult patient, they would probably not present with so many problems. At the most, they will have stagnating situations. At the most, I think children are more prone to have problems.
Which is the best method to close a tracheoesophageal fistula due to a complication of tracheostomy?
Complication of tracheostomy? Well, I think the best way is to do a tracheal resection anastomosis. So that would mean...
If there is no tracheal stenosis?
Yeah, but still, if you have the two possibilities, if it's a large fistula, you could in fact think in terms of doing it. Is it an adult or a child?
It's a child.
Okay, if it is a child, and if you have a stoma which is morassic and it is not competent, which is not static, the best option in these cases is to do a resection anastomosis of that segment of the stoma. When you're resecting it, you're exposing the esophagus. Esophagus is always closed in two layers in a vertical axis, and then in fact the trachea is a little bit similar to what the surgeon had saw. If the stoma is static, and if the levels of the fistula are different, then you can think in terms of doing a tracheal fissure, you expose it, you probably can close it. Now that would mean that you're doing an anterior approach. You can think of doing a lateral approach wherein you are going from one side, identifying the fistula, closing it, and then sort of, you can put in a little bit of muscle there or connective tissue.
Facial lata or external?
You're taking an additional incision. You have a lot of periosteum here on the sternum. You can always pick up a little bit of periosteum from the sternum and you can put it over there. So there are multiple ways of looking at it. I think it's more related to the size of the fistula. Usually, you can give it a try as an endoscopic procedure. If you have a long fistula, endoscopy is never going to work. If you have a patulous fistula, that means it is floppy. It doesn't work. It has to be if it is a floppy and a long fistula, it works. If it's a short and something which is a little bit different angulated, it doesn't work. So it all depends on how it is placed. But why not? You can always give it a try. It is less invasive. If you can get away with it, why not? So in resume, if the tracheostomy is not static and is moracic, a resection anastomosis. If it is static, either a lateral approach or an anterior approach with an interposition of that.
Different presentation and videos in this one thing is we face difficulty in course of ICU care when they try to explain the tracheostomy and they end up doing it lower tracheostomy tracheal fistula, so maybe about 2 centimeters, they must be about the carina. But two things are happening: patient is very sick in ARDS or sepsis, and we are not sure about the anesthetic, before the big surgery. And every single day the fistula gets bigger and bigger if you keep looking at it. The only way we do it is try to put a longer tube and bypass the fistula and maintain it and put a peg if it subsides. But what is the ideal time and what should be the ideal approach of repairing those difficult cases?
So if I understand correctly, the adult patients who are in intensive care who have been treated cutaneously by the anesthetist, nutritionally are not very good and you do not know when to correct them. So of course, nutritionally we have to correct them to make them surgically fit. Once they are fit, then the story will start depending upon the location of the fistula. I think the size of the fistula is also important. If it's a small fistula, one can give a try endoscopically. What harm does it do endoscopically? At the most it will reopen again, but at least you're trying. So you will know that when you're actually diagnosing it. If it doesn't improve by 2 times application, or if you have a fistula which you think is not a good idea, then you have to look for open procedures. The patient needs to be surgically fit for these patients. They have chronic aspiration. So no matter what you do, you will have to go down and look at it as quickly as possible. Because the lungs are not going to be good. If the lungs are not good, you are not in a vicious cycle. And you will have to break the cycle somewhere. So if the patient is surgically fit, I think you should go ahead and operate it.
And surgically, does the management change because you're still going to do a resection anastomosis down there? Or?
No, it depends. If it is high in the neck fistula, the advantages in pediatric clips or in recuperative clips is that they always have microtracheas and microdesicals, meaning that more than half trachea is actually in the neck. And they have a small stomach. It's always the case. In adults, if it is in the neck, then you have options, either to go from lateral side or to go straight anterior approach. The anterior approach is a direct approach. Lateral approach, I can tell you, it can be a tricky one. I'm sure you must have done these cases. It's very easy to sort of show it on pictures and everything. But to the younger colleagues here, it can be a challenge to actually go down and to make those repairs. A direct approach is much more a better approach. The advantage of a direct approach in an adult could be that you have a cartilage is already calcified. So the staticity or the stability of the trachea is not a problem. So why do you want to take additional problems for your head to go laterally? You have a cartilage that is calcified. The calcified cartilage is never going to collapse. It is going to be a problem to cut it though. But at least you don't have a trachea that is unstable. So you have both these options, either anterior or lateral.
Last previous, you were showing the type layer. They separated the trachea and the esophagus completely, stripping it off. Does the vascularity of trachea get affected because the lateral pedicule is not there anymore?
Yeah, so this is the same story that yesterday we were talking about this article by Dr.Murali many years ago. In a side radioplasty, the whole segment is completely vascularized. Circumferential, forget the posterolaterals and the laterals. So it is completely vascularized circumferential. So it's pretty interesting the vessels and the size of the vessels in an infant and the blood flow in an infant, which is interesting that we can actually tolerate these kind of vascular vessels. They can't tolerate so much of tension on the aspirations. And the muscle side that they can tolerate a little bit on the aspirated tension, but they can't tolerate on the aspiration.
Thank you so much.
When you close the radiology display, you have a double slit tracheostomy or
I don't get the question, I'm sorry.
when you close the radiology
I told you the tracheostomy question.
do you have to put a tracheostomy again with your tracheostomy or at least stage?
Well, it's a pity that I don't know whether we'll be able to talk about tracheostomy because I think one of the important things that I told Raman is just don't tracheostomy. Believe me, it is such an important topic. I have a very nice presentation, but I don't know whether we'll be able to do it. The tracheostomy comes out only when the primary cause of doing the tracheostomy is sorted out. Then you get rid of all this. So if the primary cause of doing the tracheostomy has been sorted out, the tracheostomy has to come out when you're preparing your visualized level. So if the tracheostomy is going to remain there, then you are in a catch-22 situation where you have the fistula in place and the cannula which is required as well. There is a big chance that it can be a recurrent fistula or you can have a residual fistula. You will have a difficult problem on hand. But you will have to take a call depending on by case cases. But I think it's a good idea to anticipate the problems rather than to give a prognosis to the patient or to the attending doctors. Because a lot of times the attending doctors are just going to pass on their case to you. All right, handle this. And in such cases, typically what I will do is I'll tell them that hang on, okay, the problems are these. My expectations are going to be this, and your expectations and the patient's expectations are this. So if you're very clear in your planning of the surgery, then we'll understand this. And plus, it's not going to take you for granted. The problem happens that when we do a particular surgery, it fails, and they're going to blame either us or the surgeon. They can't blame neither. If you have given a very clear surgical plan and are giving the prognostic, clear prognostic expectations of the surgical intervention. Does that answer your question?
In one of the video you showed a stiffening of the melodic segment. I mean, not related to cleft, but can you please show that part or any of the PDS? What is that PDS part?
So the whole objective is that we are looking at Malaysia, which is